fixed performance system. Now from the low flow systems or the variable performance system, there the flow does not meet the inspiratory demand. There is actually when we inhale, there is an inspiratory flow to our respiratory system. That inspiratory flow is not met, the demand is not met in these low flow systems. Oxygen is diluted with air on inspiration. These devices have limited reservoir to store oxygen and are unable to deliver consistent inspired oxygen concentration in setting of varying respiratory rates and tidal volumes. As I had said, the performance is variable. And examples are nasal cannula, very often used in the words. Face mask, cannula means cannulas and prongs. Nowadays, of course, prongs are more commonly used than cannulas. Face mask, various kinds of face masks, partial rebreathing mask and non-rebreathing mask. So these are the various kinds of this variable performance devices, low flow devices. And then the high flow systems or the fixed performance devices, they are better. It provides oxygen at flow rates high enough to satisfy patient's inspiratory demand. Actually, when we inhale, our inspiratory flow is to the tune of 40 liters per minute. So that is a huge amount of air actually which sucks in or which we suck in inside our system. That is the flow which we require. But most of the machines, the low flow systems cannot deliver that amount of flow. It ensures that the patient receives constant FiO2. FiO2 is nothing but partial percentage of oxygen in the inspired air. So that is very important. Such high flows are possible by entrainment of the room air and high flow rates and reservoirs. Examples are Venturi masks, high flow aerosol nebulizer, head box, and semi-closed anesthesia circuits. The circuit which is kept here, Bain circuit, that it can also actually deliver, it can act as a high fixed performance system. Now coming to nasal cannula and prongs, these are cannulas and these are prongs. These are more commonly used now. Deliver oxygen concentration between 25 to 45%. That means an FiO2 of 0.25 and 0.45. When we talk about FiO2, we do not tell percentage. Percentage is a wrong notion for depicting FiO2. It has to be in a decimal of 1. So if it is 25%, so 0.25. If it is 45%, it is 0.45. Or you say that 25% oxygen is being given. If you say FiO2, then it has to be a decimal of 1. At the rate of 1 to 6 liters per minute, this is the kind of flow rate, because that is very important in the wards also. Whenever you administer a flow, at what flow actually, if you want to have say FiO2 of 33, and if you deliver 1 liter flow, then obviously you are not achieving that 33% or FiO2 of 0.33. So if you, we will come to that how you calculate your FiO2 requirement for that particular patient. And after calculating that, if you administer nasal prong, then you must sort of have this formula either pasted somewhere in the ward or in ICU so that you give the proper flow. The advantages are many, of course very easy to use, well tolerated, comfortable, patient can eat and talk easily. There are many disadvantages also, dryness, crusting over the secretion and epistaxis. Sometimes because of the nasal prongs going inside the nose or the cannula, epistaxis has happened. Simple face mask. This is actually earlier this used to be the main, the face mask available to all of us. Of course, after that many other modifications have come. At an oxygen flow of 6 liters, it gives 35 to 40% of oxygen. That means a FiO2 of 0.4 is achievable. Increasing the flow to 10 liters may increase the oxygen concentration to about 0.5. But that is a little debatable, because increasing the flow through this simple face mask, because there are many exhalation ports you can see here. So if you increase the flow, most of the flow will be going out through the exhalation ports. So that's why increasing the flow in simple face mask is not advisable. If the flow rate is less than 6 liters, as the cylinder nears empty and you are not vigilant, or the sister is not vigilant, then the patient may rebreathe, because it is not a non-rebreathing mask, it is a rebreathing mask. That means patient will start inhaling its own exhalation. So thereby diluting the oxygen and causing severe hypoxia or hypercarbia. So that is one important aspect or bad thing about simple face mask. It is easy to use, of course, requires a good fit, a tight fit across the mouth, and improves humidification, and dryness is less because can be easily given through a humidifier. Now partial rebreathing mask with reservoir, I think we have got one here. There is one here because this has got a reservoir. This is a kind of face mask only, simple, but a reservoir has been attached because of that particular thing which I had said, I have been telling repeatedly, inspiratory demand. Because that reservoir acts as an inspiratory reservoir. From there the patient starts breathing directly, not from the room air. So thereby it delivers 35 to 60% oxygen at 6 to 10 liter of flow. So the first third of the exhaled gases mixed with the reservoir, exhaled gases from the upper airway are oxygen rich because of that particular reservoir which is here. And there is another non-rebreathing mask with reservoir. This is a kind of example of ambu bag. You can see that it has got also a reservoir and it is a non-rebreathing mask. And valves are here somewhere. We have got a ambu bag on the table. You can see for yourself. Delivers 95% of oxygen. The improvisation as they came by, the improvement of delivery of FiO2 was being achieved. Because that was the idea, that how much more FiO2 can be delivered to the AV patient. 2 valves added to the rebreathing mask prevent entrainment of room air during inspiration and retention of exhaled gases during expiration. So these are the idea to add valves. There is a one-way valve to prevent oxygen dilution. Tight seal is essential as usual for any mask, and reservoir bag must expand freely. If it gets collapsed, then of course the purpose of being the reservoir is jeopardized. Now comes Venturi mask. That was the invention after that air entrainment system was discovered, and the jet effect or the Venturi effect in physics, we all know that, and that came into the medicinal use. This is the entrainment port of any system. The flow is being given here, and from here the room air is being, through a narrow hole, is being sucked in, and thereby the desired dilution of the oxygen is being achieved, whereas the flow through this particular thing is not very, very high. We can see here. The air entrainment system, oxygen is forced through a jet orifice entering the mask. As there is a pressure drop across the jet orifice, here there is a pressure drop. Room air from side ports occurs through the side port, which is known as Venturi effect, as I was telling. So this is the air entrainment system, and this is the Venturi mask. You can see here that this is the mask like any other mask, but only thing, the exhalation ports, there is only one big this kind of port, and this particular sleeve actually acts for that Venturi effect. It can provide up to 40% of oxygen by mixing room air with a precise amount of oxygen. The size of the port and the oxygen liter flow determines the FiO2. The mask should be fitted to the patient as best as possible to prevent entrainment of room air around the mask, which could alter the FiO2. So that fit of the mask is very important here. And these are the sleeves which I was talking to you. 6 sleeves are available, the color coded nowadays. Each one of them has got a specific percentage of oxygen, FiO2 achievable through that, and this is the flow you require, 4 to 6 liter up to 28% FiO2 or 0.28, and 6 to 8 liter flow required for an FiO2 up to 0.4. So these are the color coded sleeves which are available. It's available with us also. So you attach your desired FiO2 sleeve and then attach the mask to the patient and give oxygen therapy. So to summarize, these are the devices which I had talked about. You can see that nasal cannula, simple face mask, partial rebreather, non-rebreather, and Venturi mask. These are the things available with us. and different flow rates which are required for efficient working of each one of them, and what is the maximum FiO2 achievable, and thereby that will actually help you to understand the requirement of the patient and to apply the particular device which would be beneficial for that particular patient and for that particular disease also. Oxygen hood, I just passing mention about it. It is only used for very small babies. It is a clear plastic shell which encompasses the baby's head. It is well tolerated by the infants. Size of the hood limits use to younger than age of 1 year, as I had said. Allows easy access to chest, trunk and extremities. Allows control of the oxygen delivery, the oxygen concentration and the inspired oxygen temperature and humidity, because these are very important issues for the child. Hypothermia is very, very detrimental for them. So those things are also taken care of very judiciously, and delivers up to 0.9 of FiO2 at 10 to 15 liter flow per minute. So this is things which are used in most of the NICUs also. So as I was talking to you, how you calculate the FiO2, like because after that only you are going to select a particular device, because you know before that this device can deliver oxygen at an FiO2 of this, or the maximum FiO2 achievable through a particular device is this. So if you calculate the FiO2 for that particular patient, then you are able to select that particular device for that patient. So for that you require an ABG of that patient. Start empirically with venturi mask at an FiO2 of 0.4 and then titrate the improvement. You see the patient respiratory rate and how our patient also, as I had enumerated, he can also be given this line of therapy. You start with the venti mask at 40%, that particular sleeve, orange color sleeve, you attach the sleeve, start oxygen therapy at 6 liter per minute, and meanwhile you get an ABG done. Say the PaO2 is showing 40 millimeter of mercury, which is pretty low. So for that patient, what you are going to do? Patient PaO2 divided by patient FiO2, desired PaO2 and desired FiO2. Patient PaO2 is 40, FiO2 in room air is 0.21. If you are giving already in 40%, you add here 0.4. I have given just room air. And desired PaO2 is about 90, because that is the critical level of PaO2 at which the mitochondrial PaO2 is around 10 millimeter mercury. So therefore 90 is the target in most of the situations, and the desired FiO2 is X. So if we calculate in this fashion, then your X becomes 0.47. That means you are going to deliver oxygen through a device which can give oxygen at a maximum FiO2 of 0.47 or 0.5. So that is, this particular calculation is very easy. Only your ABG has to be done, and then you apply the values for each one of them, and you get the desired FiO2, and therefore you can apply and choose your particular device and give it to the patient. Now, so far we have talked about the good things about oxygen, but there are a few bad things about oxygen also. So the 100% oxygen is not good for a human body for a pretty long period of time. So if the exposure is up to 12 hours, the physiological response is normal pulmonary function, there is mild substernal pain and tracheobronchitis. If it is 12 to 14 hours, there is decreasing vital capacity. If it goes beyond that, 24 to 30 hours at 100%, decreasing lung compliance, increasing PA or O2 gradient, that is alveolar arterial O2 gradient, and decreasing exercise PO2. And beyond that, say about after a couple of days, there is decreasing capacity. So there is very detrimental issues also involved in delivering 100% oxygen to human body. There are many hazards of giving too much of oxygen. How much oxygen is good, that is also very, very debatable. I have shown you the calculation for FiO2, but then you cannot do a ABG, every hour, or although that could be possibly a ideal situation, but that's not possible, feasible also. So So that's why it is difficult to really ascertain how much oxygen is good for the patient, but there is a few empirical formulas through which we go and deliver the patient what the good maximum it can do for him. Oxygen toxicity primarily affects lungs and central nervous system. The two important determining factors here are the PO2 and the time of exposure. I had just shown you that the time of exposure is so important. The higher the PO2 and exposure time, the greater the toxicity. CNS effects occur particularly with hyperbaric oxygen. Pulmonary effects can occur at clinical CO2 level. There would be patchy infiltrates, as I have shown here, on X-ray prominent in the lower lung fields and major alveolar injury. The pathophysiology, we all know of oxygen toxicity on the lungs. Type 1 cells are destroyed and type 2 cells proliferate. Toxicity is caused by overproduction of oxygen-free radicals which damage cells. Normally superoxide dismutase enzyme and antioxidants can defend against them, but in presence of high PO2 antioxidant systems are ineffective. So that is the basic background of the oxygen toxicity. And cell damage occurs and provoke immune response that worsens injury. So this is the oxygen toxicity, and therefore actually this kind of vicious cycle sets in. There is oxygen toxicity, there is increased shunting, PO2 gets lower, we feel that more oxygen is required, we increase the FiO2, the oxygen toxicity increases and this cycle goes on. So that one has to keep in mind. And how much is too much? We don't know really. More than 50% possibly for very extended periods, and PO2, more PO2, and if the PO2 is very very high, then it takes lesser time to have the toxicity features. So a PO2 of 90 is very good. Don't try to attain a PO2 of 150, 200. 90 PO2, 90 millimeter mercury is very good for any patient. Goal of ideal oxygen therapy: use the lowest FiO2 possible to maintain adequate tissue oxygenation. And there are many other complications. Growing lungs are more sensitive